Alright, good evening everyone. In this video we shall be talking about nucleotide chemistry and metabolism. Let's get started. We will be talking in terms of some MCQs. Let's see one by one. 2 days after a full-term normal delivery, a neonate begins to hyperventilate, develops hypothermia, cerebral edema and becomes comatose. Urine analysis has high levels of glutamine and it also has orotic acid. By now you must be aware that glutamine is the major transporter of ammonia in the blood and orotic acid increases in pyrimidine biosynthesis. However, the blood urea nitrogen is below normal. So, see, blood urea nitrogen is below normal. What it is pointing that urea is not getting formed. See, there is some difference between these two terms, urea and blood urea nitrogen. What is the content of nitrogen in the urea? This terminology is blood urea nitrogen. And urea, if we calculate as such, that is serum blood urea or serum urea. So, the blood urea nitrogen is below normal. Which enzyme is most likely to be deficient in this child? The answer here is mitochondrial ornithine transcarbamylase. What will happen if OTC is defective? If the OTC is defective, there will be high levels of carbamoyl phosphate. When the carbamoyl phosphate, this OTC is an enzyme of urea cycle. When there is high level of carbamoyl phosphate, it will be diverted to form more of orotic acid. And that is what is presented in this case, that orotic acid levels are on the higher side. This high orotic acid will be seen in, see, there are two causes of high orotic acid. Either it can be primary or secondary orotic acid urea. Primary orotic acid urea means it is pyrimidine defect which has led to increase in orotic acid. Secondary orotic acid urea means it is a defect in some other cycle. Here, for example, it is the defect in the urea cycle, but that has produced a defect in the that has produced high concentration of orotic acid. So this orotic acid urea mentioned in the given question is secondary orotic acid urea. So the answer is D. If there is mitochondrial carbamoyl synthetase defect, then carbamoyl phosphate will not be formed. If cytoplasmic orotidylate decarboxylase is defective, this is an enzyme of the pyrimidine biosynthesis. Then there will be increase in orotic acid, but will the level of glutamine will be normal and blood urea nitrogen will also be normal. But as mentioned in the given question, blood urea nitrogen is below normal and glutamine is having high levels. Cytoplasmic carbamoyl phosphate synthetase, if that is defective, carbamoyl phosphate synthetase is defective, then there will be no formation of carbamoyl phosphate. Again, orotic acids will be low. So this does not have, these two enzyme defects will not be accompanied by increase in the levels of orotic acid. And let's see another question. An 8-month-old infant is brought to a pediatrician because of the mother's concern about the boy's tendency to compulsively bite his fingers. These are the key words. Whenever you see these words, they are in the question. This is Lesch-Nyhan syndrome. classical presentation is always there is self-mutilation behavior. Of course, this child is mentally retarded. Compulsive biting behavior. He will keep on eating his own fingers, lips, they'll keep on bleeding. On questioning, the mother reports that she had noticed yellow-orange crystals in his diapers. This is due to accumulation of that excretion of that purine-like compounds in the urine. A genetic deficiency is Lesch-Nyhan is a defect of the enzyme HGPRTase. It's an X-linked disorder. HGPRTase stands for hypoxanthine guanine phosphoribosyl transferase, and this is an enzyme of purine salvage pathway. So it is an enzyme of purine metabolism. It is an enzyme of purine metabolism. So answer is 3 or C. Another question. A 47-year-old man presents with painful arthritis in right big toe and uric acid renal stones. This is a condition. This is gout. When it is presenting as arthritis, it is gout. Uric acid renal stones is also mentioned in the question. He has been taking allopurinol for this condition. Allopurinol is a drug which tends to decrease uric acid level. What biochemical defect would likely be found in this patient? See, you are having an increase in uric acid in the given question. Uric acid is the end product of purine catabolism. It is the end product of purine catabolism. In other words, it is, if we see from the options, it is an abnormality of the purine metabolism pathway. So answer should be 2. So answer to the given question is 2. Which of the following is the mechanism of action of allopurinol? It is suicide enzyme inhibition. Let's say I have an enzyme and this enzyme is xanthine oxidase. The substrate of this enzyme is xanthine, which will bind to the enzyme and it will be converted to the product. The product of the enzyme is uric acid. Now, when we give allopurinol is converted in our body to alloxanthine. What alloxanthine does is, it goes and binds to this site. Alloxanthine will go and bind to this site, substrate binding site or the catalytic site, and it will never leave this site. It will bind to the site and it will never leave this site. Now what will happen is, because it is not leaving this site, the xanthine when it comes, it will not be able to bind and it will not be converted to uric acid. So the levels of uric acid will decrease, and that is why we use it in the treatment of gout. High uric acid is treated by allopurinol. Another question. It's a long question. Let's try to analyze this. An infant seemingly normal at birth begins to show delay in motor development by 3 months of age. At 1 year of age, the child begins to develop spasticity and writhing movements. At age 3, compulsive biting. Another presentation, but it is Lesch-Nyhan syndrome. Compulsive biting of fingers and lips. Head banging appears. At puberty, child develops arthritis. Can you think why will there be arthritis? Arthritis क्यों हुआ? This is because it is deficiency of the enzyme HGPRTase. As a result, hypoxanthine and guanine are not converted to their nucleotide forms. In other words, What is accumulating? Purine. And what are purines going to form? Uric acid. So it is a defect in purine metabolism. It is defective purine metabolism. Let's see another question. A 20-year-old, this is again a long stem. Why I have purposefully chosen long stem is, when I have seen most of the kids, they are afraid of very long stem. Whenever there is a very long stem, 3 to 4 lines in the question, they are not able to comprehend it. So find your keywords. Every long stem question will have keywords. Let's try and find it here. A 20-year-old male presents with confusion, hysterexis, and odd behavior. Early in the morning, his mother found him urinating on the floor of his bedroom. A detailed history taken from the mother revealed that he has been a vegetarian entire life, but decided to bulk up by working out and consuming whey protein several times a day. Blood test was performed. Ammonia, orotic acid is increased. Ammonia and orotic acid is increased. What is decreased? Blood urea nitrogen is decreased. Is it orotic acid urea? Yes. What were two causes of high orotic acid? Either it is primary or it is secondary. How am I going to differentiate from primary and secondary? Primary orotic acid urea is a defect of pyrimidine biosynthesis. Secondary orotic acid urea is a defect of urea cycle disorder. So if there is a urea cycle disorder, what will happen to the level of ammonia? High ammonia. What will happen to the level of urea? No urea is formed. So there will be less of BUN. So there is less of blood urea nitrogen. And what about pyrimidine mein? Pyrimidine mein ammonia levels is normal and your urea levels is also normal. Both of these are normal. The patient began with hemodialysis and was given oral sodium benzoate. This is used in the treatment of high ammonia, hyperammonemia, and even phenylbutyrate is used to remove glutamine from our system, which improved his condition. Gene therapy of which enzyme product would correct his condition? Of course, you can see the answer, but again, if we see it from urea cycle point of view, it is a defect of ornithine transcarbamylase. And what ornithine transcarbamylase converts? It converts ornithine to citrulline. Another question. A 6-month-old boy, progressively lethargic and pale, shows delayed motor development. Lab investigations reveals normal blood urea nitrogen, serum iron is low, hemoglobin is low, leukopenia, less of cells are seen. His blood bone marrow shows marked megaloblastosis, which does not respond to treatment with iron, folic acid, vitamin B12. None of these pyridoxine is treating this condition. His urine developed abundant white precipitate identified as orotic acid. The underlying defect causing the megaloblastic anemia is most likely which of the following pathways? What is pyrimidine pathway going to form? If there is a defect, see, we now know that pyrimidine synthesis in the end will form pyrimidine. That makes sense. So it will start with carbon dioxide and the donor of ammonia is glutamine. Via series of reactions, it will first form orotic acid, which is then converted to cytosine, uracil and thymine. And let's say the enzyme which is going to convert orotic acid to the other three is defective. What will happen to the level of thymine? There is no thymine. And what will happen if there is no thymine? That will result in megaloblastic anemia. So it is a defect in pyrimidine biosynthesis. Then a 3-week-old infant has been having intermittent vomiting and convulsions. She also had episodes of screaming and hyperventilation. The infant has been lethargic between episodes. Tests reveal an expanded abdomen and blood values showed decreased citrulline. We just discussed OTC converts ornithine to citrulline. So if this is decreased, ornithine is increased, as well as decreased blood urea nitrogen. So it is a defect in the urea cycle. What other clinical outcomes would be expected in this case? There will be increase in blood glutamine and increased orotic acid. Why will there be increase in glutamine? Because glutamine is the source of ammonia, and ammonia will be combining with carbon dioxide by 5 steps. It is known as urea cycle. It is converted to urea. And if the enzyme OTC is defective, ammonia will increase, glutamine will increase, and hence there is increase in glutamine. Of course, carbamoyl phosphate, which is accumulating, will enter into pyrimidine biosynthesis to form orotic acid. So that is the link. The carbamoyl phosphate is the common link between pyrimidine biosynthesis and urea cycle. Another question, a 12-week-old infant with a history of persistent diarrhea and candidiasis is seen for respiratory tract infection with pneumocystis carinii. A chest X-ray confirms pneumonia and reveals absence of thymic shadow. Trace IgG is present in his serum, but A and M are absent. His RBC completely lacks an enzyme essential in purine degradation. The product formed by this enzyme is, have you heard of a disorder known as ADA defect, resulting in severe combined immunodeficiency? In severe combined immunodeficiency, both B and T cells are defective. Both B and T cells are defective. As a result, what happens? Now, because both B and T are not working, the child will present with severe combined immunodeficiency, and hence the name of the disease KID. This ADA, we do not know the exact mechanism why it is affecting only T and B cells, but what we know is it converts adenosine to inosine. And if this enzyme is defective, what is the product? It is inosine, and hence the answer is C. Patients with Lesch-Nyhan have hyperuricemia. I told you about this, indicating that purine biosynthesis is increased. Markedly decreased levels of HGPRTase enzyme or HPRT, one and the same thing. Hyperuricemia is explained on the basis of decrease in which regulator of purine biosynthesis? It is IMP. IMP is going to form both AMP and GMP. If somebody is having HGPRTase defect, then there is no formation of IMP and hence no formation of AMP and GMP. So the common regulator for both adenine and guanine synthesis is IMP, and hence the answer. An anti-cancer drug 6-mercaptopurine is deactivated by the enzyme xanthine oxidase. Try and understand this question. 6-mercaptopurine is deactivated by the enzyme. That means it is converted like any other protein. Xanthine oxidase converts 6-mercaptopurine to, let's say, uric acid, because all purines are ultimately converted to uric acid. A cancer patient being treated with 6-mercaptopurine develops high uric acid, hyperuricemia, because uric acid is getting formed more. The physician decides to give allopurinol. What will allopurinol do? It will bind to xanthine oxidase and inactivate it. This kind of enzyme inhibition is suicide enzyme inhibition. Let's see what the question is asking. What will be the effect of allopurinol on the activity of 6-mercaptopurine? See, what allopurinol will do, you have 6-mercaptopurine which is converted to uric acid by the enzyme xanthine oxidase. Allopurinol inhibits this enzyme. The mechanism is suicide enzyme inhibition, and 6-mercaptopurine will become now available as an anti-cancer drug. Earlier it was getting converted to uric acid, but after giving allopurinol, it is now having retention and potentiation of activity of 6-mercaptopurine. Which component of the DNA duplex causes the molecule to have net negative charge? The negative charge is present due to the phosphate groups. The ribose is also having negative charge, but the phosphate is highly negative. So the negative charge is due to the presence of phosphate groups. All of the following are pyrimidines except you have cytosine, uracil and thymine as pyrimidines. Adenine is a purine. It is adenine and guanine is your purine. A patient presents with painful arthritis in his right big toe and uric acid renal stones. He has been taking allopurinol for his condition. What biochemical defect would be found in this patient? See, the patient will have a defect in the purine catabolism. It is a purine metabolic pathway. Answer is B. So that will result in high uric acid levels, and that is why he is on allopurinol. That explains everything. High uric acid on the basis of decrease in which regulator of purine biosynthesis? The key regulator of purine biosynthesis is inosine monophosphate, because this is the one which will give rise to both AMP and GMP. What is the structure indicated? What is this? You have a nitrogenous base. You have this nitrogenous base, a 9-membered ring. Of course, it is a purine, but this purine is attached to a sugar. It is just attached to a sugar, but there is no phosphate here. So we will call such structures as nucleoside. If to the sugar at 3rd or 5th carbon you have phosphate attached, now this structure will become nucleotide. And why we call it purine nucleotide? Because adenine is attached here. This is the structure of adenine here. If guanine will be attached, it will be called guanosine. If only phosphate is not attached. If phosphate is attached, then we will call it guanosine monophosphate. The way I have attached phosphate here, now the structure has become adenosine monophosphate. You have to know the difference between adenine and adenosine. Adenine is the purine. When I call it adenosine, it becomes purine nucleoside. Similarly, guanine becomes guanosine, cytosine becomes cytidine, uracil becomes uridine, thymine becomes thymidine. Which molecular feature listed causes duplex DNA to exhibit a near constant width? The DNA is a double helix structure, but it has a constant width of around 2 nanometer or 20 angstrom. Of 2 nanometer and 20 angstrom. This is because the pyrimidine nitrogenous base always pairs with the purine nitrogenous base. You always have one pyrimidine on one side and it is always pairing with another purine. So it is purine, pyrimidine always. Like adenine always pairs with thymine and guanine always pairs with cytosine. The bond between them is hydrogen bonds. So, another question, which of the following components are found in DNA? Will you find phosphate? Yes. Adenine? Yes. And ribose. Will you find phosphate, guanine and deoxyribose? You will not find ribose, but you will find deoxyribose. Will you find cytosine and ribose? Cytosine already means that it is having the sugar in it. So this is not possible. Thymine and deoxyribose. You have thymine, deoxyribose, but you do not have phosphate in it. So something is missing. I have a better answer. I'll go for B. A phosphate group and adenine, but where is the sugar then? So, the components which are found in the DNA are phosphate, purine or pyrimidine and the deoxyribose sugar. Another question, amino acid which contributes to the formation of purine ribonucleotides are all except. So, the purine ribonucleotide, it's given in this is for your help so that you can answer this question. Aspartate is part of it. Histidine is not part of it. Glutamate and glycine are part of the purine ring. So glycine forms carbon 4, carbon 5 and nitrogen 7. This part comes from aspartate, and nitrogen 3 and 9. They are coming from glutamine. So glutamine is the source of the two nitrogens. In the given options, glutamate is given. Probably it's a transcriptional error. Glutamine has to be mentioned. Anyhow, histidine is not involved anywhere. Even glutamate is not involved. Glutamine is involved. So which of the following amino acid forms the carbon of purine synthesis? Aspartate, yes. Glutamate, yes. Glycine, yes. But not serine. Serine is not part of the structure. Lesch-Nyhan syndrome is deficiency of which of the following enzyme? Said it several times. It is HGPRTase defect purine salvage pathway. The HGPRTase belongs to salvage pathway. Another enzyme of salvage pathway is APRTase. Like we have hypoxanthine guanine phosphoribosyl transferase. A is for adenine phosphoribosyl transferase. Similar terminologies. Which of the following enzyme is inhibited by allopurinol? It is xanthine oxidase. Xanthine oxidase requires a must cofactor, and that is molybdenum. Molybdenum is a must cofactor for xanthine oxidase. Which of the following enzyme deficiency does not lead to hyperuricemia? If somebody is having xanthine oxidase defect, it is going to convert xanthine to uric acid. In other words, uric acid will not be formed. So this is the only cause of hypouricemia. Glucose 6-phosphatase, HGPRTase, aldolase B defect, all are associated with hyperuricemia. With this, we have covered your few questions on nucleotide chemistry, metabolism. I wish you all the best. Thank you.